TAVR indication, low risk, may be too risky. As I told before, this is a rhetorical phrase, because asking me if is low risk is too risky, I would say no, it's not too risky. Why? When we started in 2007 with the CE mark valve, these are so-called early generation valve, the core valve and the sapien, we were performing this procedure as also Eber Grube told you in his lecture, in patient very, very sick, very old, high surgical score, risk score, very frail, with a lot of comorbidities. So this patient would be classified now as futile or prohibitive. But despite this, we have really surprising mortality, 15% in 1 year. This is the registry, Italian Core Valve Registry, published in 2011, is all-cause mortality. As 3 years also, the mortality was all-cause of 35% and only 13% of cardiac mortality. So we have very good performance of this procedure, despite the patient were very, very sick. And very soon we understood that if we were performing this procedure in patients with lower risk score, like 20% of the logistical score was used as cutoff, we had really better outcome, both with Corval and with also the Edwards. These are data from the source. Was a post-market registry conducted in Europe, was very, very precise. You can notice how patient with 40% of risk score had mortality of 30%, and less than 20 was much less, was half, 20%. And also we learned how the procedure had the learning curve of the operator, of the proctors, of the hospital, or post-procedural care, and also of the patient selection. And this is one paper, but there are a lot of papers published on this topic, where the patient or partner family were divided in tercile, and so the third enrollment tercile T3 had really much better outcome respect to the first. So because we have to learn how to do it. This was a process very continuous, because we were performing a lot of proctor meeting session at the time, and I was younger, but I had Professor Colombo and Dr. Gube as a mentor, so we were developing the procedure. And so we were able to overcome a lot of complications that were much more common in the times, like cardiac tamponade, because now we have dedicated pressure-shaped wires, like Confida, Safari, or others, and we reduce a lot the left ventricular perforation, or we're using different temporary pacemaker catheters. At the beginning, it's strange to say, but we had a lot of cardiac tamponade due to pacemaker perforation. We have much less, almost no lateral acceleration, because now we are learn how to have a good pre-planning of the procedure. We have really sophisticated software with CT scan. We know much better how to define the anatomic aortic valve apparatus. So I'm saying the LVT, aortic valve, aortic root, and also the sinotubular junction. We learned to use undersized balloon. We took 2 years to understand if we were to use a 1:1 or 1 or 0.9 ratio of the balloon. We reduce a lot of the cerebrovascular accident and also coronary obstruction, because now we have better planning, we have better selection of patients, but also we have available different valves, so we can select the best valve for the patient. This is a trend of the all-cause mortality reduction up to 1.1, but a lot of very experienced center, the mortality is 0. So I'm not surprised about the data that Raj Makar showed us in that paper, because in some centers really we have no complication, and this is due for 2 reasons: better patient selection. Maybe patients are also intermediate risk, so are better outcomes. The stroke is also reducing 2.6%. This is not also, again, not surprising me, because in our experience, at least in Italy, we never had a cerebrovascular clinical stroke more than 5.5%. We'll use the power leak because we have different valve. We are capturally positionable. Look here, this is the old core valve. We very often was implanted too low, too high, but now this is not a problem anymore. And also we can see how the decrease of the PVL also, because we have new valve with some kind of skirt which are reducing the leak. Vascular access, better management, less major bleeding. This is one of my first case. I ruptured the iliac artery. I sent to surgeon, but now I am able to, and we are all able to solve with endovascular procedure. And pacemaker. The pacemaker is still a problem, but you know, this is the first experience. Up to 40% of pacemaker implantation now is dropped to 11.7. This is the experience with Evolut RCA study. Saying that, the problems are the same that Rajin showed you, the durability. But about durability, I'm confident because our valves, the transcatheter heart valve, are having very good performance at 5, also 8 years. We had this problem also with clinical thrombosis, but we are going to solve with different management. Bicuspid valve is a problem, but is not a problem with the new generation. We can see how we have now much less complication, and also the mortality is much lower than tricuspid valve. This is because these patients usually are much younger than the classical degenerative aortic stenosis. Pacemaker is still a problem, but we saw that is reduced. The cost also is reducing. So, in conclusion, given by the first experience from 2007, when we start with very sick patient, now we are going to the intermediate low risk. I am very confident that we are going to extend this procedure to low risk patient. And again, and I agree that our choose surgery against transcatheter will be only the anatomic problem. Thank you.